Hi, everyone. Welcome to Whitley Penn Talks, where we give you valuable insights to help you make confident, informed decisions and move your business forward. My name is Kendall Jones, and today we are talking Healthcare Transparency Act. Joining me today are John Karp and Jolee Patnaude. I'm so excited to have you both and to get into this discussion today. So before we do that, let's go ahead and have each of you introduce yourselves. So John, we'll start with you. Tell us a little bit more about your role at Whitley Penn and the kinds of clients that you focus on.
So my role at Whitley Penn here, I've been a tax partner here since 2011 when I joined, and I've specialized in the healthcare industry. And myself and a few of the other partners, we run our healthcare group. And healthcare has always been an ever-changing and dynamic discipline for us to be in, and we have really just trying to keep up with the times.
Awesome. Well, we're happy that you're here. And Jolee, newer to the firm, tell us a little bit
Yes.
more about your role and what you focus on.
I'm new to Whitley Penn. I am the Revenue Cycle Management Director for Consulting. I've been doing healthcare for 30 years, but I've been focusing on revenue cycle management for about 25. I'm certified in coding and compliance, and I've been doing billing for a very long time. That's kind of what I do, and it's what I enjoy.
Awesome. Well, thank you. And for those listening that may not be incredibly familiar with revenue cycle management, can you tell us a little bit more about what that entails and what parts of the billing process you consult on?
So, revenue cycle management in healthcare is basically from the time that the patient calls to set up a appointment or come into the facility all the way until the claim is paid or the patient pays their balance. So it's from the whole process. And I've been doing this for a very long time, and I consult on everything from registration or patient access, coding, documentation, medical records, HIPAA, billing, and then your final collections, patient financial. So it's basically the whole process.
Awesome. Primarily for hospitals, specialty, doctors' offices, or the like, both of them.
I've done multiple service lines from home health and hospice to physician practices to hospitals, RHCs, which is your rural facilities, and rural health clinics. Basically, as I like to say, basically the gauntlet. There's
All of
not
it.
too many that I haven't touched. About the only ones I really haven't delved into is like your DME facilities.
Hey, so
Um,
Jolie, for those who might not know what DME is, what is that?
so DME is durable medical equipment. So that's like if you need like your oxygen tanks, your walkers, your wheelchairs, beds, that kind of stuff. That's what your DME falls under. Um, I've done it in facilities and such, but I've never actually just worked for a DME. It's a very specific area. But yes, I mean, I know it because of coding and such. So yeah, but that's pretty much what DME means.
Awesome. Well, thank you for sharing a little bit about that. Our resident healthcare experts for sure. So we're excited to have both of you on and to talk a little bit more about healthcare cost transparency and some of the changes that we've seen just this week in this space. So I know there was an executive order that came out earlier this week focused on updating the Healthcare Cost Transparency Act that originally came out, I think, in 2019 and has been updated a couple times since. So there was a Bloomberg article focused on it and just a lot of conversation around the topic so far this week. Jolee, can you tell us a little bit more and break down how we got here? What's the current executive order looking like? And what was the original act attempting to do starting in 2019? How has it been updated since? And what are the implications there?
Sure. So in 2019, the original act was to basically make it more consumer based so that the patient would understand what they're paying for, why the cost was the cost for different services that were being rendered. And it initially was supposed to basically help the patient to make an educated decision as to, do I go to this hospital? Do I go to that hospital? And just kind of be able to, as they say, shop around.
Yeah.
That was the initial. A lot of facilities or hospitals kind of were like, okay, we'll do the best we can because they do have to create two separate platforms of how this is displayed. One is consumer friendly, so that's specifically for the patients, and the other one is mainly for like your insurances and CMS to look at. And
And for
CMS is
those
your
listening, CMS.
Yep, is your central medical services. So that's basically your Medicare, Medicaid, and those areas are kind of fall underneath that. And then, so initially it was set up to start doing that, which some did start putting it on their websites, which is the easiest way to look this up. And then in 2022, it was upgraded because a lot of them weren't doing it. So initially there was only like 14% that were actually putting it through their systems and making sure that this was updated on their websites. And then in
that's
2000
14% of hospitals.
of
correct?
hospitals, only
Okay.
hospitals. This only affects, the way it's worded, it only affects specifically hospitals,
Okay.
or anything that falls underneath that hospital criteria. So then in 2022, they beefed it up, because previously they were only having to pay like up to about $100,000 a year in fines if they got fined for not having this done. But in 2022, they upped it to $2 million per year that they could be charged. And so in some research that I did do, the hospitals that did actually get fined in the last year or so, there was a hospital in Chicago that got fined for the year $847,000 for not having this updated on their website and not having the proper thing that the patient could actually go and look up. So they can use a CPT code, which is what they're given of what they're gonna, the service that will be performed. And
Define CPT code for everybody.
so the CPT code is a current procedural terminology. So this is something that is used in healthcare so you're not writing out that the patient went in and had a CT scan with contrast. There is a code attached to that specific service. So then that way it can be put on a claim form that's sent into the insurance. It's a setup that helps, so it's not everything is. It's kind of more encompassed under the code, so it's easier for people to, or I shouldn't say people, for the systems to process.
Gotcha.
And then, so for now, in the newer act in 2025 that was updated again, the previous acts said estimate. So this would be something that, you get in there and you'd be like, well, we can estimate that this is how much this is going to be for the patient. Now it's like actual cost. So you actually have to tell the patient, if you go in for an x-ray, it's going to be $150, where previously they'd be like, you're going to have an x-ray done, it might be $125, plus or minus, whatever amount that the facility decided to put on there. But now it has to be the actual cost. So there are specific services that it falls underneath this. The list is mostly your diagnostic. I mean, there are other things in there. And it does include the ED, which is your emergency department. So this actually falls underneath there, which can be kind of confusing for some, because coming into the ER, you come in because you don't, that's an emergent situation, or you feel like this is something that's, urgent. So there's going to be kind of a hit and miss I think on this, just due to the fact that you can't really say it's going to be a level 2 and then the patient gets in there and it's a level 3.
Right.
The cost is going to
Like,
be
what
kind
would a
of,
gunshot wound be?
that's like a level 4, level 5. So that's like your ultimate trauma,
But-
and only specific facilities can take those types. So,
Well, what if, Jolee, what if I go in and I'm level 2 trauma? I mean, how does that experience affect the patient? Do they have to re-quote the new procedures immediately? Do they not do treatment because they didn't effectively
oh, no.
determine
So
that? Okay.
there's regulation and laws that you have to stabilize patients irregardless, no matter what.
Right.
So in this context, it would be more the fact of, if the patient asks, then they would probably have to do it. But I'm thinking that in the long run, this is going to be something, because at this point, they don't have everything spelled out as to how this has to, come forward for the patient. So for the emergency departments, I think it's going to be more along the line of, this is what, you're coming in as this is going to be the cost that we can tell you right now until we actually look at you and figure out exactly what's going to happen. Because they're not going to know if they have to give the patient morphine, or if the patient can't have morphine and needs codeine. And so there's all these little different things that happen. So, I mean, they call it practicing medicine for a reason, not just, you you're going to come in and we're going to know right then and there to do this, and this. It's really not as easy as, as I like to say, as you see on TV. So
Yeah.
it's a lot. There's a lot
Not
more
like
to
Grey's
it.
Anatomy.
No, I really wonder. Yeah, the first time I watched that and I was working in the hospital, I'm like, wow, where did they get this? I've never seen this
Who did
stuff.
they consult?
So I think the emergency rooms are going to be the hardest part of
Yes.
this
Yeah.
because there's, as Jolie said, there was years ago, there was called the EMTALA, if I'm pronouncing
EMTALA,
it right,
yep.
law that passed. And that what that says is they're not even allowed to ask you if you have insurance when you walk into the ER. Right? Like, I mean, they're supposed to triage you, take you in right away.
Whatever you need.
Whatever you need, and you might be unconscious, so you're definitely not asking how much it costs. So I think that's going to be the one part of this that is going to be tough. The interesting part is if you look at most insurances, right, you always have an ER copay plus a percentage,
Yep.
and it's that percentage is which is what's going to hang everybody up. It's because it's a percentage of what number
Yep, exactly.
from an ER visit.
Yeah.
Right. So the ER is going to be the tough part.
Yeah, so I think when they start really kind of breaking it down, the conversations that I've had, some people are just like, they hope they just kind of push that one off to the side and be like, yeah, we'll do it as much as we can, but they shouldn't be hung up on that part because like John just said, if they come in unconscious, is the family going to be like, yeah, we don't know if we want to pay that? I'm like, seriously, just, it's just
and
one of
they're
those
not
things you
gonna
just
say,
kind of look at that
"Go to a
going,
different hospital."
right.
Yeah.
Yeah, exactly. Mm-hmm. Yeah.
Very true. I think too, the other conversation we had as we were prepping was focused on surgery centers and where they fall within this. And I know, John, you had a good example of how surgery centers don't need to currently comply, but they exist within hospitals. So it's, where does that stand?
well, Right. So just personal just happened, right? My 17-year-old got their nose broken playing basketball. And so to go into the surgery center to have the nose reset, they don't ask you any questions. I mean, they don't really tell you how much they think it's going to cost. They'll tell you what your copay is, right? That's your deductible or those things. But it's a surgery center and it's billed separately, even though the surgery center is within the hospital. It's not billed as the hospital. It's billed as XYZ Surgery Center. And so this doesn't apply to them as of yet.
Right.
Right. And so, which is kind of interesting. And I think more and more procedures for the consumers are being done in surgery centers if they're day procedures versus true hospitals.
Yeah. A lot of people feel more comfortable doing them like that.
Yeah.
Well, it's quicker. It's faster.
Yeah. You don't have to deal with all the hospital. Well, we can't take you right now. We have such and such going on. So yeah, there's a lot of that going on.
Yeah. Aren't there, and I may be wrong in saying this, but aren't surgery centers often in suburban areas kind of more spread out as well, or no trend there?
I
No.
I
There's
don't
probably
think
more
there's
in
a
the
trend
city
now.
of Dallas than you
Yeah,
can
yeah, that's
imagine.
true.
Like you go down the tollway, you can see several in the
That's
city.
true. I was thinking more from like convenience and people just having a surgery center closer to them than
And
a
some of
full
them,
hospital.
some of them do specialize. Some just do general, and some like specialize in orthopedics. Some specialize. So yeah, you might see that kind of trend.
Yeah, very true. Anything more there, Jolie, on the current order, or anything that you'd like to add to hospitals complying over the last few years, or anything like that?
Yeah. So they did do a update. So right now there are 54% of the hospitals across the nation that are compliant, and there's still 46% as the end of 2024. So at this point, there's probably a push to get more on board. Some hospitals will just take the hit and do the fine because
Yeah.
either they can't get the IT to work or they just don't have the ability to update their websites. The biggest thing that kind of kicked off, I do believe the reason why they made it specific as the actual cost is because the data that was collected in the last couple of years of putting this information together was that some hospitals, depending upon how the patient was either brought in or who they were seeing, it doesn't really go into super detail as to why, but that there was different costs for the same tests, same procedures, same, that type of stuff. So there was a question as to why was this patient charged this, but this patient was charged this other cost. So this is where the estimate, and I'm doing air quotes, the estimate is kind of where the whole, did you give the estimate? Is this what the patient wanted? Or, is there something that you did for the patient? There's a lot of scenarios that can happen, but actual cost, it should be the same across the board. It should be, one patient shouldn't be $50, and because this patient over here has this type of insurance, it's only 75. And so, those types of things. So I think that's what their concern is. And it also is just to make sure that they get to make an educated decision on their care. A lot of people just, well, I go to this hospital because that's where I've always gone. They don't double check things. They don't see that the cost has gone up, because just like any other industry, everything has gone up in healthcare also. And I think a lot of people just think that it's just expensive, period. And healthcare is expensive. I'm not going to, say any different, but there's reasons as to why. And, it's not just as simple as, it's not a shirt. It's not a pair of pants. There's a lot behind the tests that you do. There's a lot behind the pharmaceuticals that you get. There's a lot behind the care that you receive. It's not just somebody walking in going, yeah, it looks like you did something to yourself, and this is what we're going to do for you. It's not that just let's try this kind of thing and see what sticks. It's someone who's actually knowledgeable, educated, and they've spent the time to learn all the different things about the human body. And, if it's depending upon what you're there for, there's a lot to it. So that's the reason why some of the cost is higher in some cases. And I know a lot of people don't understand that, but I mean, like when you buy a car, do you really understand what goes into, putting a car together? I don't, but sometimes I look at the price going, my God, really? So, yeah.
So I'm on a committee at one of the local hospitals, and one of the things they did is they described why the Tylenol cost $100. Like they took us through the spreadsheet of what happens to get the Tylenol to the patient.
Yep.
So you don't really you just think about the fact that you have the bottle in your medicine cabinet, but you don't pay attention. Okay, there's a nurse, there's tracking, there's input into a chart that you got it to make sure everybody knows that, okay, at 12 o'clock you got a Tylenol, so you can't have another one until 4 more hours. Like there's like the touching for that one medication is not what you would have at home.
Right.
And so that's how come it costs $100 to get it in a hospital.
Yeah.
Versus getting it out of your medicine cabinet.
Right.
So, and I actually just want to key in on one of the components that when Jolee was talking about the fines and the penalties, realize most governmental fines and penalties are not deductible. And they haven't really ruled whether this would be or not. My gut is it's not going to be deductible for taxes. And so also recognize is that you have two types of hospitals. You have for-profit hospitals and non-profit hospitals. Well, if a non-profit hospital has to pay a fine, well, it doesn't matter anyway. If a for-profit hospital has to burn cash without a corresponding tax deduction, that means people are paying tax on that money now.
Yep.
So when you look at $1 million or you look at $2 million, you could end up flipping into a taxable situation pretty quick.
Yeah,
So,
good point there.
Yeah.
and then that's it. I think the other, like I know we've kind of talked about the patient, and I think where this really comes into play for everybody that works with us is we represent some small hospitals. They're going to have make sure this is in place. And then it's really also about everybody out there, that the whole idea is that, like Jolee said, that you're putting the power into the patient. But one of the parts of the transparency is they think it's going to lower costs because it's going to create a competition that then as just patient consumers can go in and say, well, gee, if I can go to the hospital around the corner versus the hospital 3 miles away, it's going to cost me less. I'm going to go 3 miles away.
Right.
And it's really putting the power with the patient and empowering the patient population. And it used to be that when maternity coverage used to be extra on a policy, like consumers would say, okay, so do I want to buy up into the maternity coverage, or how much does it cost me to negotiate with the hospital and have a cash baby? Like I can go in and just write a check to the hospital. And the interesting part is all three of us could have done that, and all three of us would have been given a different number at the same hospital, because one of us may have been able to negotiate better. And now they're saying, no, we're all going to pay the same cash price if we were to go make that phone call.
Exactly.
Yeah, and then you can call 3 hospitals instead of get 3 different numbers at the same hospital.
Yep.
Yeah,
Right.
very interesting. Well, that kind of brings me to our last question here. And when we were prepping, we talked a lot about patient education and how that has an impact here, and knowing what your policy covers, knowing what the hospital can and can't do by way of cost. And Jolie, what would you say for people listening just as patients? I mean, what's your recommendation to stay educated, and what are your thoughts there?
So the biggest thing I think, and this is something that I do stress a lot, educating patients is huge. You should understand your plan. You should understand what you're paying for. A lot of people, you'd be like, well, what does your plan cover? And they just look at you like, I have no idea. I'm like, did you read your plan? Do you know what your copay is? Do you know? It's amazing, but a lot of people are like, I don't even know where to look for that. So the part that I love is like, do you have your card? Yes. Look at your card, because a lot of insurances will put on there, if you go see like a primary care, it's $15 or $25 copay. Or they have a number on the back that you can call them and go, yeah, so I'm going to the facility for this, or I need to go get an x-ray. How much is this going to be out of my pocket? You can ask these questions and they will tell you. So, or I should say they're supposed to tell you, let's put it that way. But, read your policies before you sign up for them. Understand what you are covered for, what's not covered. It amazes me how many people think that, oh, I can go to the chiropractor. And then they find out after 5 visits, I have absolutely no coverage for chiropractor. And those are not cheap. I mean, everybody knows it. This is just one that I know is something that everybody thinks they're covered for because they're quote unquote a doctor. But it's like, no, you're not covered for chiropractic. So there's all these little things that a lot of people don't pay attention to. And I mean, I'm not talking just young people either. I've talked to everybody in all age ranges that have absolutely no clue as to what's covered and what's not covered. And the first thing I say is, what's on your plan? And they're like, well, I don't know. Did you get like an updated plan? Did you, and a lot of people don't pay attention. So educate the patient is huge. And this could just be from anything from just like, call your insurance, go on your, every insurance has a website. Most of them have portals that you can sign up for, that you can actually sign in, look to see what your coverage is, and see if you can, get certain things, or what your copays are, or when a claim does process from a facility or a doctor, it'll say right there, you owe $250 because you went and got a CT scan, and this is what, before you actually get that paper explanation of benefits. Or in some cases, they put it through their website and you don't ever get a paper EOB. You don't know that. So these are things that people need to make sure that they are educated on. And I'm going to keep saying educated because that is the key word here. And it goes across the board. I've been in healthcare for a really long time, and I've worked with people in healthcare that have no idea what they're covered for and have no clue what they're going to get if they go into, to see a doctor. I'm not kidding. It's funny.
Yeah.
I mean, I've had nurses go, why is it this much? I'm like, you went and saw the doctor. Well, it shouldn't be that much. Well, okay.
And realize that even your practitioners or the folks at the front desk, because we have obviously copays for different things with our firm policy, and it always amazes me that my kids or myself will go to see a specialist and they'll charge me like a primary physician, and they'll say, oh no, this is all it is. And I'm thinking, you're going to send me a bill in a month.
Right.
And they don't even understand, even though they're supposed to be looking at it, they don't read the cards correctly either. It's usually me trying to say, well, look, why don't you charge me this amount versus, right? So I don't have to worry about it later.
I'll pay a little extra right now.
Check,
Just in
great,
case.
right? Right. I know I'm going to owe it to you. You've done this for 2 years now. And it's just an amazing, but so it's like even that front desk person doesn't always understand the various policies that the practices are taking and what the true costs are.
Yep, and that comes in with your eligibility checks. So, yeah, that tells me that they're not reading it or don't know how to read it. You'd be surprised somebody of them just like, yep, you got coverage, you're good. You can go see the doctor. It's like, what kind of coverage do they have? So,
Yeah. What are you going to
those little
send me as a
questions.
surprise in the mail in a few months or a week?
Well, and that's actually what's like this hospital price transparency to go just kind of funnel us back that way.
Yeah.
That's actually part of this, right? There should be there's been a lot of talk and a lot of legislation on no surprise billing. And the transparency should really be doing 100% away from that surprise billing.
Yeah.
For the day.
Yeah, the No Surprise Act
Definitely.
is another one that people are like, what do you mean? What does that, how does that work? So yeah, there's another one out there that's very intricate for healthcare that a lot of people don't understand either. So
Yeah. Maybe that'll be a part 2. We can break that down on our next episode.
okay.
Awesome. Well, we are just about at time, so I appreciate both of you for taking time out of your days to sit and talk through healthcare cost transparency and some of the nuances there with the news and just updates that we've seen coming so far in 2025. I'm sure there will be more along the way, but for now, we'll wrap this episode, and thank you all for listening. Again, you can subscribe on Spotify, Apple, listen right on whitleypenn.com/podcast. So thank you all.
Have a good day.
Awesome. Thanks, guys. And cut.
We're done.